My name is Lady Marie, and I'm the Support Network Officer for London. I have a level C5 complete spinal cord injury, and it's been 28 years. Damien?
Hello, everybody. My name's Damien. I'm one of the nurse specialists working for the Spinal Injuries Association, and this is my third week here. Prior to that, I was working at Salisbury Spinal Centre as a clinical nurse specialist in the outpatient department for the past 25 years. And as part of that role, I was tissue viability lead for the spinal centre.
Okay. Debbie?
Hi, I'm Debbie Green. I'm also one of the nurses here at SIA. I left Stoke Mandeville Hospital 5 years ago and helped set up the nursing service for SIA in February 2016. I'd had 25 years of experience working at spinal injuries at the NSIC. Getting confused.
Don't worry, we're not recording.
No.
Thank
Okay.
you.
Right. Any other representative from SIA here? No? Okay. Now, without further ado, I'm going to hand you over to our wonderful Damien, who's going to talk to us about stopping the pressure.
Right. Thank you very much, Lady Marie. So I was asked if I could, participate in this Zoom cafe today. Off the back of my background as tissue viability lead for the spinal centre, I just want to stipulate that I'm not a tissue viability nurse specialist. I'm a spinal cord injury nurse specialist, but the role that I undertook at Salisbury, the majority of the patients that I was seeing were patients with pressure ulcers. So a lot of the work I was doing involved collaboration with tissue viability nurse specialists, which when I first started getting requests or referrals from them, I did sort of question myself as to why it is that tissue viability nurses are asking for advice about wound management. But it became very, very apparent that although their knowledge of wound care is exceptional, it's dealing with somebody with a spinal cord injury, which makes the whole management that much more complex, because you're dealing with lots of different agencies. If somebody with a spinal cord injury has a pressure ulcer, there are so many different aspects that we're looking at in order to come up with a management plan, the most effective management plan for them. And that does involve liaising with various different services like wheelchair services, therapists looking at posture, seating, social services looking at additional care if that's required. So I felt that I was almost like the coordinator of this patient's care, rather than giving specific information about wound management, because the tissue viability nurses were quite adept at that. But I also link very closely with the plastic surgeons in Salisbury as well. But before I get on to that, the aim is always to try and manage our patients conservatively at home, not to bring them into hospital. So I would work very closely with the tissue viability nurses and the community nurses, just to help coordinate that plan of care. And I'd always much rather get given a referral, just to assess a red mark rather than a grade 4 pressure ulcer. And I'm quite happy just to talk about some of the terminology that we do use, because I'm very conscious of the fact that it's very easy to get sort of engrossed in medical jargon. But I'd much rather identify the cause of a pressure mark, manage that problem a lot more quickly, rather than feeling that community teams or the patient themselves were struggling with a wound that gets a lot worse, and then it just becomes a lot more of a complex issue that often requires much lengthier management. So that was certainly the aim, manage everybody at home, but that's not always possible. So sometimes, the patients do require surgical intervention. So I was part of the plastics pathway, primarily, identifying these patients to the GP and advising the GP about the referral process, but also just, scrutinizing, if you like, the appropriateness of these referrals to the plastic surgeon, because I think plastic surgeons, by their own admission, a lot of them don't have a lot of positive dealings with patients with spinal cord injury, or the outcomes aren't always positive for various reasons. Whereas I've often found that somebody that's managed through a spinal injury center with the umbrella support of the staff at the spinal center, often the outcomes are much better. So if a patient does come in for surgical management, we can get that wound healed, and hopefully with the right support and advice, we can get that wound to remain healed, and also look at, what caused it in the first place and address those issues, so that we're not putting the person back into the same situation of what caused the wound in the first instance. So yeah, my collaboration with the plastics team, was a very close one. I got involved in the early stages of referral, and then the patient would come into hospital, have their treatment, and after that, their home situation, their equipment, everything was in place to make sure that they had the best outcome, from their treatment in Salisbury. So that's a bit of a background of me. I'm quite happy just to, if you've got any questions for me, please go ahead, because I'd much rather, interact with all of you and just answer any questions that you may have.
Okay. Does anyone have a question? Indicate by picking your hand up, if anything. Okay, we've got Brian on mute.
Hi, I had a very small abrasion at the bottom of my skull, which went into about S1. Is there, and I've lost quite a lot of weight deliberately, 4.5 stone, which means my back is very distorted now, and my scar, bottom end is not looking very good. What sort of thing would be best for me?
I think when it comes to, managing scar tissue, that's almost a separate area from wound management, but it's a very, very important aspect. Scar tissue doesn't have the same sort of elasticity or tensile strength and tolerance to pressure as normal healthy tissue. Scar tissue tends to be a lot more fibrous, and some people might be under the misconception that if it's more fibrous, it's tougher. But you need the elasticity within the skin to increase that skin's tolerance to pressure. So how you manage that scar is very important, and one of the simplest ways is just to make sure that scar tissue is moisturized. The more it's moisturized, the more supple that scar tissue will be. The drier it is, the less robust it is. But it's not just managing the scar, it's also making sure that you can minimize the pressure over that area of scar tissue. So if you're a wheelchair user, looking at the amount of pressure that's over that area, if it's right down in the sacral area, looking at the back of the wheelchair to try and alleviate the pressure there, as well as looking at your posture to make sure that you're not applying so much pressure in that area is very important as well. So in a nutshell, the advice would be making sure that the scar itself is managed through moisturizing, close monitoring, and looking at what might be causing pressure over that area.
Thank you.
You're welcome.
Anyone else? Unmute yourself. No
Yeah, sorry. Yeah, I've got a question because you can't see me. It's Naomi. I can't put my hand up.
Hi, Naomi.
Hi. So I've got I've got quite a lot of spasticity in my right arm. I'm a tetra,
Yeah.
and I've got I've got flexion, quite a lot of flexion in my right arm, and
Okay.
I've got like pinkness in the crook of the elbow. That's how to describe the elbow, if you know what I mean.
Yeah.
The bit
Yeah.
at the inside of the elbow. So I had some Botox the other day, and I'm getting stretches, and we're putting Cavilon on it, but I'm just a bit anxious about it. The skin isn't broken; it's just a bit pink because it's flexed at about, I don't know how many degrees it's flexed, but it's flexed. So it's getting pressure on it.
Okay. So pressure more through tension by the sounds of things as the skin's being stretched. Is that correct?
Well, it's more that the skin is being, the arm won't stretch out. The arm is like semi-bent.
Yeah.
Because it's flexed. It's like at about what, 70 degrees. I don't know what degrees it's at. I don't know if I put video on. I don't know if I could even show you.
Okay.
Let me just see if I can put video on, see if that will work. No, I can't get anywhere near it.
Okay. But if I just get up a little bit more, you're talking about, can you see
Exactly
where I'm just
Yeah,
pointing there? So it's in the crease of
That's right. And
the arm there.
the way you're holding your arm is
Yeah.
similar. I can open a little bit more than that, but my arm is in a similar position to that. And it keeps going more and more closed. And where your other hand is, that's where it is. That's where the redness is. Yeah.
Okay. You know, with patients that do get, you know, contractures, you know, the more contracted the area is, then the more prone it is for the air not to be able to circulate around that area.
Yeah.
So, you know, the skin can get more moist, and you know, moisture can affect you know, the skin's integrity. I think as far as managing the contracture, you mentioned that you've had Botox. You know, the Botox is really most effective, you know, with follow-up treatment to provide, you know, stretches to be able to, you know, stretch that area. But as you're stretching that area, I think you know, sorry, I've got the cat's about to jump over the laptop, so I'm keeping an eye on the cat. But I think, you know, with you know, a contracted limb, you know, managing that area of skin is similar to, you know, managing the scar tissue. You know, it's keeping it moisturized, but you need to make sure that you know, the skin is intact as well. You know, if the skin's broken or if it's looking vulnerable, you know, potentially, you know, the Cavilon is the right thing to be using to protect the skin from moisture. But I think as you know, the contracture eases to a certain degree, just a regular moisturizing cream, you know, a non-perfumed moisturizing cream will probably be fine. And I'm presuming that the skin is intact at the moment. It's just looking pink.
Yeah. How do you mean intact exactly?
As in that the skin's not broken. There's no broken areas in the skin.
It's not broken. It's looking. It's looking not far off from that.
Okay.
I don't know how to describe it.
So I think, you know, there wouldn't be direct pressure there, so it wouldn't necessarily be pressure damage. It would be more, you know, perhaps like a dermatological issue, which, you know, the Cavilon is a good barrier. You know, it helps repel moisture. So, you know, I'm happy to have a chat with you. You know, perhaps, you know, we can arrange to, you know, have a chat perhaps after this meeting.
Yeah, yeah,
And
sorry,
can-
because I was a bit late, I didn't catch your name.
It's Damien.
Damien, yeah. Yeah.
And I can ask one of my colleagues perhaps just to get your mobile number, and then
Yes,
maybe I
super.
could just give you a call afterwards. And
Yeah.
because I think it's very difficult to try and give precise information, without actually seeing what the actual issue is.
Yeah,
But maybe
if you
can,
phone me afterwards, I'll be able to take a picture of it. Yeah.
that'd be perfect. Thank
Okay,
you.
Lady Marie's got my number, so she can give it you.
Okay, that's perfect. Thank you. I'll give you a
Ever
call
so much, Damien.
after this.
Yeah, not immediately after. Maybe if you phone me tomorrow, because I'll be preoccupied immediately after. Is that all right?
Yeah, no problem. Well, I can have a look at my diary, and yeah, we can arrange a time that's suitable
Or
for
you could
you.
text me. Yeah.
Yeah,
Text
no
me.
problem. Well, I'll get your number perhaps from Lady Marie.
Okay, so folks, sorry to dominate proceedings.
Sorry.
No, don't worry.
Charlotte was the next person to ask a question. You're muted.
Thank you so much. Yeah, sorry, my name's Charlotte. I'm really pleased to be here and invited here. I work for Stoke Mandeville Spinal Research. So just
Hi, Charlotte.
hi. We fund research in 4 areas: urinary tract infections, pain, upper limb function, and of course pressure ulcers. And this might be a
Whoops.
prevention, treatment, and care of pressure ulcers. Is there a particular, angle that you would be helpful to you in the field?
Sorry, Charlotte. I don't know if it was just me, but we missed the beginning of what you were saying then. So I just caught the last sentence, really.
Oh, sorry. Can you hear me now?
I can, yes, yeah.
I think it might be the hospital Wi-Fi. I work for Stoke Mandeville Spinal Research, and we fund research in UTIs, pain, upper limb function, and pressure ulcers. So I was just wondering how you can see research helping in the prevention, treatment, and care of pressure ulcers. If there's any kind of particular research that you'd like to see that would ultimately have benefits for people.
I think the preventative measures are always a key area of focus, because we want to try and make sure that as many patients as possible don't reach the point where they require surgery. As far as the equipment that's out there, I think the equipment is out there, as far as cushions, mattresses, but I think from my point of view, how our patients are developing pressure ulcers in the first place, there's multiple reasons, and I don't think there's one single identifying factor that I would suggest, that would be the primary focus. We're very aware that as our patients age, their skin integrity isn't as robust as it used to be. And when I talk about aging with spinal cord injury, I don't necessarily mean old age. It could be an 18-year-old that's been living with their spinal cord injury for 20 years. How they manage their day, their daily life, the pressure on their shoulders, their ability to transfer. Just looking at them globally, that's often part of what I would do in order to try and I don't know, keep them as independent as possible without, putting their skin at risk. As far as, a particular angle, for research, I think, the equipment companies that deal with, pressure ulcers, with, cushions, mattresses, the equipment is so sophisticated now. I think the hardest thing is to try and relieve the pressure to a degree where the cushions, mattresses can, reduce the pressure, effectively, to make sure that, our patients can be up in a wheelchair, all day if they want to be, without, sustained pressure in that area. I'm conscious of the fact, I'm not really coming up with a definitive answer because I don't know that there is, a clear answer.
Sorry, who's on mute?
Sorry, was I on mute?
No, just somebody else is wanting to jump in with a comment. Is it Ali?
Okay. You're on mute, Ali.
Hello. One area that I would really love research into a little bit more is a product called Amicapsil.
Okay.
I had a pressure ulcer on my ankle, and it coincided with COVID, and it was being dressed weekly by district nurses, and it continued to get worse and worse and worse. Every week it was worse, until I learned about a product called Amicapsil.
Yeah.
And absolutely, it was game changer for me. And I don't know what you know about it, Damien, and I think it's a huge area for research that really needs.
Yeah.
Spell that.
It's AMICAPSIL.
Okay.
So it's
Sorry, David,
interesting that.
Sorry, just before you continue, there are a number of comments in the chat box. So if perhaps you could open the chat box, Damien, because there are some questions there. People are asking questions as well.
Okay.
Yes, sorry.
No problem. I'll answer Ali's question first, if that's okay, and then I'll open the chat box. So my experience with Amicapsil, I was involved in a very small trial in Salisbury. The owners of the company approached the spinal centre looking for patients that would be interested in trialing the product. And they were quite clear with their criteria for the types of patients that they wanted. And those were essentially patients with chronic ulcers that have tried various different treatments with very little effect. So my part of the trial was to identify patients that are willing to participate in it, and then working closely with the community teams. So for the others that are listening in, what Amicapsil is called passive immunotherapy. And, I won't, claim to understand exactly what that means, but basically it's made by a company called Willingsford Healthcare. Thank you, Mike. The company's based in Southampton. It's owned by a couple called Frank and Jeanette Wills Dodd. Sorry, the cat's trying to make an appearance. So it's a new product. It's not available on prescription, and I think that's one of the key challenges at the moment. That my experience of it is in a very small group of patients, but the benefits have been significant, as you've experienced. But I think at the moment is trying to get it out into the wider market so that it can become easily available to other people.
Can I make a comment on that?
Sure.
I use it. That's my go-to should I have any issues, because I've discovered that what the district nurses provide, with all of the goodwill in the world, it just does not do the job. And the moment I use the Amicapsil, I'm there. It's sorted. Okay. And the problem I think they are finding is that a number of trusts are not willing to try the Amicapsil, and therefore, because I believe from what they've said, the company has said is that they want it to be available on prescription for individuals to be able to use, but it's to get the healthcare professionals in the community on board, willing to try it. That's where the difficulty seems to be.
Sure.
Sorry, how do we get hold of it?
So there's two different different ways, really. You can either purchase it yourself, but it is relatively expensive. I think off the top of my head, and please don't quote me on this, it's about £60, I think, for a small vial. It looks like white powder. So the way that it works, it works through not osmosis, but it sort of draws the bacteria away from the wound bed, and it also draws the exudate as well, you know, the fluid from the wound away from the wound bed. So it will get rid of, you know, the harmful bacteria, but it will leave behind the healthy bacteria that, you know, our bodies carry. So you can purchase it yourself. A small container about the size of a thimble, you know, will cost about £60. But yeah, please don't quote me on that because I'm not certain of the price. Or you can request, it's called an independent funding request, to get funding for the product. So that is something that can be initiated through the community services. And you know, that can be initiated by the community nurses, but it means that you do need to get support from healthcare professionals that would essentially advocate its use. So it's a more complex process, but you know, those at the moment are the two main options: either self-purchasing or, you know, getting an independent funding request for it.
But with that such a small amount, how much would you use?
That depends on the size of the wound. So if you imagine, yeah, it is literally about the size of a thimble, and you're just sprinkling this powder into the wound bed to cover the wound bed. Of course, the larger the wound, the more that you would need. And I think the advice is that it does need to be done daily. So it might be, you know, one little thimble if it's a large wound, may last, you know, a couple of days. You know, if it's a smaller wound, obviously that will, you know, stretch it out a bit more.
Okay, thank you.
But I think, you know, just on, sorry, just before I finish on amicapsule, you know, what I would say is that, you know, from the limited use that I have seen, it has been very effective. But I think if you were to use it, I would still probably suggest going down the route of the dressings that are available. But if you reach a point where you've tried various different products and it's not made any difference, you know, amicapsule is possibly, you know, a good option. But I think as soon as it's you know, available, you know, to be prescribed, then it's going to be more widely available.
Okay, thank you.
Okay. Right, we have two people, and I need to, there's a question in the chat that was put in earlier. Somebody's on bed rest and they wanted to ask a question.
Okay.
And then we will have, is it Soxa? So then you'll be the next one to ask the question. Right, who is it that put the question in? Who's on bed rest? Do you want to ask the question?
Hello, yes, it was me. I'm on bed rest. I had a grade 4 pressure sore in around June time. I was getting treatment for it. The treatment was just gradually making it worse. I managed to get amicapsule, but every time I wanted to use it, I have to leave it in there. Nurses were coming daily to change the dressing, and they said if I use my own form of treatment, they're going to close my file. And the amount of exudate that's coming from the wound, the amicapsule won't last very long. And they've attached a vac pump to the pressure sores are on both sides, on, you know, the trachanter, the
Trachanter.
The trachanter, yeah, sorry.
Yeah.
And that's where the exudate is coming from. On my left side, it turned into osteomyelitis, and it did on my right. So until the osteomyelitis has gone, I daren't use the amicapsule because, you know, I won't know if it's, you know, it'll just be going to waste.
That's right. I think, you know, osteomyelitis, you know, which is infection in the bone, you know, sort of into the bone marrow more specifically, is quite complicated to treat. You know, it does require often long-term antibiotics, you know, for weeks, you know, weeks and weeks of antibiotics to try and address the issue with the osteomyelitis. It can just lay dormant, for weeks, months, and years. So, if the osteomyelitis certainly needs to be addressed first before you would hope to get any sort of wound healing. And there are various ways to sort of determine whether you have got osteomyelitis, whether that's through things like MRI scans, but in the first instance, just simple blood test to look at the infection markers in the blood will give you a good idea as to what if there is any sort of underlying infection that needs addressing. So amicapsule in that respect, I think you're right. It's not going to make any difference if you have got osteomyelitis because that needs to be addressed first.
So I've just in on a Zoom meeting. I just wanted to listen in on it because it's got Damien, our nurse specialist, the new one.
Carl, you need to mute yourself.
Oh, sorry.
Yeah, can I just add, with the vac pump, I was also told that the wound won't close until the osteomyelitis has healed. And there's a lot of exudate coming. If the wound is closing, is there still a danger of the tissue or the bone still being infected?
Yeah, so generally, the Vac therapy, Vac therapy is, Vac is one type of treatment, sort of more widely known as topical negative pressure. There are lots of different companies that produce similar systems. The Vac stands for vacuum assisted closure, which is, a product that's made by a company. It was called KCI. I think it's KCI Acility now. But one of the contraindications of using Vac therapy, you should be very cautious if you're using it with osteomyelitis. Osteomyelitis and Vac therapy or topical negative pressure, if you were to use it, generally the recommendations are that the osteomyelitis you need to have active treatment and the infection markers need to be significantly low. Otherwise, really it should be stopped until the osteomyelitis has been addressed properly.
So I think my osteomyelitis hasn't been addressed properly. My infection markers are in the 80s, and I just had a 6-week stay in hospital, and they were going up and down, and I had IV antibiotics, and now they've just discharged me yesterday with oral antibiotics, and so far I think it's just staying steady. I don't know if it's going down. The wound is closing with the Vac therapy, but I don't know if it's dangerous for it to close and the damaging tissue or bone is still going to remain there and then maybe surf up again.
I think, with the infection markers, because you are on antibiotics, you've had the IV antibiotics and you're on the oral antibiotics now. Sometimes the infection markers can take some time to start to lower. So in that respect, that certainly needs to be kept an eye on because, so long as the trend is that the infection marker is coming down, potentially it might still be safe to use the Vac therapy, but it does need close monitoring, with the infection markers, which they would get from blood tests. But I would suggest, any change in that, if the infection markers don't come down or they start to creep up, I think the advice would be that the Vac therapy should be stopped until that osteomyelitis is reassessed.
And would it need to be operated on, or is there any other way of, any other way of getting rid of the, tissue or,
That would be a decision for a surgeon. What I can say is that sometimes some people refer to osteomyelitis when in fact the issue might be reactive osteitis. And just very, very simply, what the difference is. Osteomyelitis is infection deep down into the bone. Reactive osteitis is an infection on the surface of the bone. So if someone's got, and and I've heard many times, you know, people being referred to as having osteomyelitis, and it's been the other, it's been reactive osteitis. With reactive osteitis, sometimes what can be done is just simply removing that infected surface of the bone. And you know, you can continue with the antibiotics as well, and then the wound should start to heal, you know, providing you've got the right conditions, which is keeping it infection free, you know, clean, warm and moist, which is, you know, the sort of 3 basic principles of wound healing. So if you don't have any infection, you know, you have the dressing on to create the environment for the wound to heal itself. You know, there are lots of other considerations, of course, relieving the pressure. And, you know, that might sound like a real obvious one, but obviously, you know, the clue is in the name. You know, pressure ulcers are caused by pressure. So in order to, you know, maximize, you know, the best outcome, relieving the pressure is vital. But also as well, just, you know, looking at your overall health. Certainly in Salisbury, there is a nutritional pathway which we would advise people to follow, and that essentially encourages additional protein supplements and vitamins just to help with the wound healing.
Okay.
Okay, thank you.
Viv. Thanks, Viv. The next person would be Soxa, and after that, there's a question from Julia Wingfield.
Okay.
It's Stephen Spring. I couldn't get the typing right when I did that.
Okay.
Damien, obviously prevention would be better than treatment.
Absolutely.
Is there any particular clothing that we should use? I'm thinking about, there's a product called Parafictor underwear. Is that helpful, or have you used it, or any experience of it?
So I think, you know, historically we were always talking about, you know, making sure that the clothing you wear has natural fibers, you know, allowing the skin to breathe and not sweat. And I'm sort of thinking back that, I don't know, you know, I was born in the 70s, and, you know, nylon was, you know, everybody was wearing nylon. It wasn't particularly breathable. You know, you probably leave a trail of static electricity behind you, but, you know, your skin would sweat in it. So hence, you know, the recommendation for natural fibers. But I think nowadays, you know, materials are a lot more, you know, sophisticated. You know, some of the synthetic materials will wick away moisture. But generally, as far as clothing is concerned, something that has, you know, stretch in it. So, you know, something that's going to stretch with your skin. So to give you, you know, like an adverse example, you know, just a pair of, you know, thick denim jeans, your skin's not going to stretch well with a thick pair of jeans. Making sure that things like seams, you know, buttons, you know, rivets, you know, try and avoid things like that. You know, if you're a wheelchair user, you know, there's nothing to stop you from wearing jeans. Jeans, you can get stretchy jeans, but, you know, things with lycra, elastine in them, so your skin will stretch with it. I think, you know, one way of trying to describe the effect is that if you were to sit on a concrete block, you know, the pressure going through your bones is going to be a lot higher. So, you know, if you're wearing a thick pair of jeans, your skin is not going to stretch, and you know, with a thick pair of jeans in the same way that it would with something that's a lot stretchier. Because what we want to try and achieve is that, you know, whether it's a pressure relieving cushion, that you maximize, you know, the ability of your cushion to reduce pressure. And generally that's by immersing as much of your bottom within the cushion and distributing the pressure more evenly. And your clothing will help. So something that's stretchy, that will allow your skin to stretch, you know, in with the cushion, to immerse your skin in the cushion, is better. You know, we often recommend, you know, with regards to footwear, to make sure that shoes are 1 to 2 sizes bigger than what you would normally wear, which will just allow, for any sort of swelling of the feet not to cause pressure within the shoes. Socks, sometimes they would have a seam, maybe consider wearing, socks inside out. But I think that's probably, the sort of general idea with regards to clothes. Synthetic fibers are good in some respects because they can wick away moisture, and getting moisture away from the skin will help with the skin integrity, and clothing that will stretch as well.
Okay. Thank you, Damien.
Okay.
Julia?
Yeah,
sorry, go ahead.
thank you, Lady Marie. I have in the past multiple surgeries over both my ischium and my sacrum. And last time I was in hospital for 8 months altogether, and came out, and I have to say the last lot of surgery was pretty traumatic, but I have great faith in the fantastic surgeons that looked after me this time round. I went back to hospital. Whilst I was in hospital, unfortunately what keeps happening is I get a pocket underneath the actual scar tissue itself over my ischium. It's measured 4 centimetres by 5 centimetres.
Okay.
And it fills with fluid, and then what happens is it just bursts through every so often. Now, I went back to my spinal unit, I think a couple of months ago, and they did an ultrasound, and they were delighted to see that there was no fluid to draw off because it had grown beautiful. You could see it, lovely tissue in there.
Yeah.
But the radiologist did warn that at any time that could get reinfected. And I've noticed in the last couple of days that there's a slight roundness to it, a slight puffiness.
Okay.
And today it's almost milky coloured underneath.
Okay.
And I'm just a bit cautious because I think altogether I've had 8 surgeries on it, and I've had I had osteomyelitis as well, and they've taken away a considerable amount of bone there, including most of my coccyx, and my ischiums are both shaved down, and I've had sepsis 4 times. So I dodge bullets. I just wanted some advice as to what I should be doing now.
I think in the first instance, if the skin is feeling puffy, then that needs some attention, and your first port of call would be the community nurses. And I guess there's a slight sort of hierarchy as far as the route that you could go through, but certainly community nurses first, because a lot of community nurses, they're very experienced in wound management, and most community nurses will have spinal patients on their caseload as well. So, it might be that they've had, that experience of dealing with spinal patients with pressure ulcers. The golden rule, and it's the hardest part of my job, is to say to somebody, if you've got a wound or, an area of what looks like pressure damage and you're going to be sat on it, you need to not be sitting on it ideally.
Go to bed.
And it is bed rest. And that is the hardest part of my job, over all of the years I've worked. Because, what's going on underneath the skin, by getting up on it is potentially going to make it worse. But certainly it sounds like it needs somebody to come out, have a look at it. If the community nurses, if they're not sure, then they can contact the tissue viability nurses. But equally, can I ask which spinal centre you're under?
Yeah, I'm under the NSIC. In fact, I'm going to SPOP tomorrow because I'm seeing my colostomy nurse. So I was thinking I might just sort of raise the issue there and just say, look, because someone just quickly have a
And
sneak
sorry,
peek.
NSIC, is that Stoke Mandeville?
Yeah.
So I think Hester Dunn works at Stoke Mandeville.
Yeah, we love Hester.
So I'm sure they're all very busy, but it's certainly worth just phoning ahead to say, if there is the possibility, you know, I've got a concern over my skin, could somebody have a look at it?
Yeah.
They
I
can.
was wondering, I don't have great faith in my community nurses. I have lots of experience of them in the past, and they've been at best clueless.
Okay, but that might be something that you know, Hester can support the community nurses with. I
Yeah.
think, you know, if you've had that area assessed, then, you know, I don't know how things work at Stoke Mandeville, but I think, you know, if there's any concern, they would be linking in, you know, with your community services, and, you know, at least just giving some advice as far as what you should do, or whether you need any sort of further investigation to see whether there is, you know, any further underlying damage. But, you know, the other advice would be, you know, if it becomes an ongoing problem, you know, just being reviewed by your wheelchair services to have a look at your posture and your seating to make sure the equipment
I've
that
got a
you
new
have got.
chair, and I've actually got a Roho, and I've got a Roho on my commode chair as well. So, you know,
Okay.
I am fastidious, over obsessive when it comes to pressure relieving. Drive everyone nuts on leaning to and from. But
No, that's
thank you very
good.
much.
And can I just ask as well, your Roho, have you been taught how to check it?
Well, it did actually deflate about a week ago, and it hit the floor. I had a leak, so I've re-pumped it. I don't know if it's overinflated, but no, I haven't been taught how to.
So that might be something that, you know, when you go to Stoke Mandeville, if there's somebody there that can at least just check the cushion for you. Otherwise, it would be a matter of going back to wheelchair services.
Right.
They would be able to advise you, because certainly the Roho cushions, they're you should be sat immersed in it. If they're overinflated, you could be a bit like a pea on a drum. So you need to sit
Yeah.
in it, and often a correctly set Roho will look underinflated. So there's often the temptation, you know, to put a bit more air in it.
I'm
But
wondering if that's what I've done.
so yeah, wheelchair services, or most wheelchair services, would have access to pressure mapping equipment. So, you know, but generally the simple test with a Roho is just sliding your hands underneath. And if you slide your hands, if you're able to do that yourself, you literally slide your hand underneath the bony part of your bottom, palm down, and then and then you should only be able to push down about an inch before you feel the base of the chair. If you're having to push down, if you're having to push down more than that, then I'd suggest the cushion's probably overinflated.
Oh dear, I'm overinflated.
Okay, so but when you go to Stoke Mandeville, if there's somebody there that's familiar with, you know, dealing with the cushions, it's worth asking. But you know, certainly, you know, from Salisbury, everybody's very busy. You know, we're always trying to accommodate people as best we can. But if you contact them beforehand, yeah, it might be that they say, we can't see you at that exact time, but if you're willing to come in half an hour before or half an hour later, you know, hopefully they'll be able to see you and just at least reassure you that, you know, get the cushion set properly, because sometimes it can just be fine margins that will that can affect why your skin's not as tolerant to pressure as much as it should be.
Yeah, I think when it deflated and we found the leak, I think my instant reaction was, quick, shove some more air in. And I think perhaps I've overinflated. Thank you for
okay.
Sorry,
there are good, you know, sort of simple instruction videos that you can get online. So the company that produces the Roho cushion, they have instruction videos. So just going into Google, you know, how to set a Roho cushion, you'd find a YouTube video on there that can just, you know, show you how to check it yourself.
Great, thank you very much.
You're
Thank
welcome.
you.
Well, good luck for tomorrow.
Yeah, fingers crossed. Thank
Yeah.
you.
Thank you, Julia. Julie, I believe you wanted to ask yourself, please.
unmute myself. Mine is a very trivial question when I listen to all the horrendous things that these other poor people have got to put up with. I had a pressure sore just below the level of my coccyx. Took about 2 years to heal up. I had a tissue viability thing. It's all quite tickety-boo now, but I have a protective dressing on it, which has kept it good. And I have it changed about every 8 to 10 days. Now, my district nurses are at variance with each other on the pros and cons of having a protective dressing. I have found, and I buy my own dressings as well, just so that, and I get a retired nurse who puts a dry dressing on. My skin is intact. I just wanted to know what your opinion was. If we take the dressing off and somebody pushes me over uneven ground and that, I split open again. And that's what this half the district nurses say, oh, well, when you've got a problem, tell us. But I don't want a problem again. That was agonizing. And my protective dressing is keeping me good. I fly, I can do transfer, I can do everything. Advice, please.
Okay, so my experience with medicine is that everybody will have different opinions, so that doesn't surprise me that your community nurses will have varying opinions too. Most dressings are designed for wound treatment rather than wound prevention, although there is one particular company that their products are licensed for pressure ulcer prevention as well as pressure ulcer treatment. So I'm not sure if I'm at liberty to be able to suggest specific dressings, but in a nutshell, there is a particular dressing that is licensed for pressure ulcer prevention as well as treatment. The way that this particular dressing works, it's a foam dressing, and there's lots of different foam dressings on the market, but it has like little waves cut into the foam as well, which just allows the dressing to stretch with your skin. So if the dressing can stretch with your skin, that will reduce the pressure going through the bone, through the surface of the skin. Often I think, with patients, we have to treat every patient individually, and it's what works for you. I think if the dressing is working and you're only using one dressing approximately every 8 days, then
it's called an Alevin gentle border dressing, and it does seem to work for me. But I wanted to know, they say you shouldn't wear that dressing because the skin's got to toughen up, and I hear what they say from that point of view, but for me, this has worked now for 12 months with this protective dressing on. I don't really have any problems. But I just needed to ask you. That's really why I came.
No, so I like I say, I think you'll always get differing opinions. I think, all I would suggest is if you've got something that works for you and it's clearly it is working, then it's worth sticking with it.
Thank you.
So I would stick with it. It's not going to do you any harm, and I'm trying to be very diplomatic, that all of us, as we get older, our skin loses elasticity. Skin's ability to tolerate pressure is reduced as well. So if you've got something that helps right now, then I certainly wouldn't have an issue with that.
No, I'm 88, and so I know that my skin isn't what it was when I was in my 50s, but it's pretty good. It's standing up. Thank you very, very much indeed. Thanks.
You're welcome.
Okay,
so this was about protective dressings. So I know it's always been quite controversial. Even when you worked in a spinal injury centre, it was quite controversial whether people should wear protective dressings on a healed sore or not. But maybe for Charlotte, maybe this is something for research as to whether this is, whether they do really help or not. And in fact, the ISCOS conference that happened, the ISCOS conference is the International Spinal Cord Society conference that happened earlier in the year. there was a presentation or actually it may not have been the ISCOS conference, it might have been the European Pressure Ulcer Advisory Panel conference actually, where they did have a study that was performed looking at protective dressings on people's heels and how successful they were. And they reported that they felt they had quite good results from that. So I don't know whether that's something that Charlotte's team might be able to look at.
No, I think that would be a good idea, because you know, we know the impact, you know, a pressure ulcer can have on a person, and it's, and there's a couple of aspects there. You know, that there's the financial impact that it has on the NHS, you know, that literally billions of pounds are spent each year treating pressure ulcers. But there's the human cost as well. You know, I've mentioned before that for me, having to tell somebody that they need to be on bed rest to, you know, improve the condition of their skin is the hardest thing that I've had to do in this job, because often I get asked the question, well, do you mean, you know, just spend a couple of hours in bed in the afternoon? And often it's no, you know, it could be days, weeks, months. But, you know, I guess, you know, one thing to get out of today is that, you know, don't underestimate the seriousness of what might look like quite an innocuous mark. If you see a pink mark and it doesn't blanch, meaning when you press it, if it's red and it stays red when you press it, you know that the damage underneath is more significant. But if you have a red mark, it's worth just putting some time in bed rest to get rid of that red mark, rather than persevering with your daily routine with the potential that that wound might break down. Because, you know, I'd much rather have, you know, photos of red marks sent in, advise on that, rather than it breaking down and becoming, you know, a category 4 pressure ulcer. And the management is just, you know, much harder then.
I'd like to ask a question, please, if possible. I know, excuse me. Right, you said red mark. Now, for people like myself, whose pigmentation is quite dark, how do we spot something that's just beginning to start?
Okay, so with dark skin, this week is Stop the Pressure Week, and we've been working in collaboration with a company called Tally, and bear with me, they've got some very good little guides. I'm just going to see if I can hold that up to the screen. I don't know whether you can see that.
Yeah.
So that just gives an idea of you know, how darker skin, you know, what it would look like, feel like. But with darker skin, it's not just, you know, visually looking at the skin, it's feeling the skin as well. And you're feeling for sort of raised areas, changes in temperature, because a pressure mark or the start of a pressure ulcer, it might feel warmer than the rest of the skin. But often with darker skin, a pressure mark will appear darker than the surrounding skin. So, you know, it's a combination really. You know, I appreciate that, you know, it's easier to spot a pressure mark on whiter skin. But, you know, with dark skin, a combination, having a look at the skin, feeling it, checking for raised areas, checking for, you know, any sort of, you know, changes in temperature of those particular areas.
Thank you. Well, we've got 1 minute. I should say we've actually got over by 1 minute. Anyone have any last question? Oh, Debbie, did you want to say something?
Yeah, it's not a question, but again, this is for Charlotte. That, you know what, but sometimes we see people who have who get a small mark or a small sore that, you know, you think we should be able to get healed up quite quickly, but it's almost impossible to heal. And in fact, the deterioration is really rapid in that sore. And it's almost like, you know, people explain to us that they've not been able to stop that deterioration. It just keeps getting worse, whatever they do. And I wonder if there's some way that we could look into what causes that acceleration in some people, and how can we try to reverse that acceleration. It doesn't happen to everybody, but for some people it seems to happen all the time, that as soon as they get a mark, it breaks down really, really quickly. And I don't know whether that's also something that you'd be able to look at, Charlotte. I don't know.
Thank you so much. Yeah, I mean, all of these I'm scribbling down, and it just gives, it's just really helpful to be able to zone in on certain aspects that we might be able to encourage the researchers to look at. Thank you so much.
Excellent. Right. Well, thank you everyone for coming. Sorry, Damien, did you want to say?
Sorry, Lady Marie. Just before everybody does go, I don't know if we've got Sophie still online at the moment. But the Spinal Injuries Association, we have produced a poster which just covers the sort of the key aspects of what we're trying to make people aware of, what to look out for, where pressure ulcers might occur. I'm not sure if Sophie's still online at the moment.
Yes.
Okay.
Yeah, I'm here.
Sophie, would it be possible just to bring up, just to share on the screen, the poster, please?
Yes, give me 2 secs.
Thank you. Because I think, the poster, it can be a really useful resource, which, hopefully, that's something that, we can share more widely. And it's just to remind people of, the basics of how to look after their skin.
Okay, I'm sharing my screen now, and feel free to then talk through.
Thank you. So this is a poster that's been put together by the Spinal Injuries Association, and like I say, it gives some very sort of straightforward advice about checking your skin, how to look after your skin, keeping hydrated, well-balanced diet. So and with the diet, it's not, we're not asking for anything specific. It's just making sure it's a well-balanced diet, because certainly when I worked on the spinal unit, particularly in the early days, our patients were a lot younger, and every takeaway in Salisbury knew exactly where the spinal unit was. So our patients weren't eating, a lot of them weren't eating the right things. Being able to relieve the pressure, whether you're a wheelchair user or even if you are up on your feet as well. And the way that we used to suggest that was often pressure lifting, but we're very aware that what we want to try and do is maintain your shoulders, keep those in as good condition as possible for as long as possible. So the pressure relief, if you're in your wheelchair, could be something just as simple as leaning forward, leaning side to side, to relieve the pressure. So I think it's a very good poster, just to sum up what you need to do really, or what you should consider to help try and avoid pressure ulcers from occurring in the first place. And I think this post is going to be shared through our social media platforms.
Will it be on the website, Sophie?
Yeah, it's already on the website.
Yeah.
In the news section of the SIA website, there's an article and there's a link through to the PDF there.
Okay, so you can all look at it on there, if that helps.
Yeah, I'll pop the link through to the webpage in the chat box in a sec.
Right, thank you.
Thank you, Sophie. Right.
Thank you.
Okay, well, thank you, everyone. It was a very informative day, and I hope we all learned something. I certainly have. Just before you go, if you have a few moments, we usually end with a quiz. It's not about what we discuss, but just to end on a lighter note. So if you have time, it's only 10 simple questions about what's been in the news this week. Okay, so get your pen and paper.
As I say, they're never simple. They're never simple questions.
Yeah, it's all to do with stuff that happened in the week.
I haven't
Come
had
on.
time to watch the news because I've been preparing for this Zoom cafe.
Oh, come on. Not that.
And I've been watching Friends because it makes me laugh. So
Sophie,
I've left them.
Sophie, could you let me co-host? I'm sure you can stop recording also, so we don't need to.
Yeah.